The title of today's presentation is as follows: The use of glucocorticoid therapy may give rise to the paradoxical post-infection cardiac sequelae, worsening the clinical outcome of COVID-19 patients with elevated neutrophil activation. A case report from two severe COVID-19 patients. First of all, this is not a real clear finding, but I've got to confess that I started off with an hypothesis. So this is a hypothesis-driven research, which looks at the important topics that is really well debated among the researchers and clinicians at the moment about COVID-19, such as glucocorticoid therapy, the cardiac complication, and neutrophil activation. Points of the study, or presentation rather, is that dexamethasone, or a form of steroid or a glucocorticoid, is an anti-inflammatory agent that is commonly utilized in clinics as a symptomatic relief against COVID-19 disease. Its popularity mainly stems from its very low cost. It's cheap, and because of the influential paper that was published in NEJM, which is the go-to publication that all doctors use for their diagnosis and treatment, and it was particularly this clinical trial called Recovery, which proved that glucocorticoid is actually beneficial. However, the efficacy and toxicity of dexamethasone is debatable. Many recent studies claim that the steroids have no benefit in cohort level, yet side effects may occur. And the neutrophil is a main driver of acute inflammatory disease. However, glucocorticoids have been repeatedly shown to be insensitive against neutrophil. So we suggest glucocorticoid therapy may paradoxically aggravate progression of COVID-19 and its complications through promoting neutrophil activation survival and consequent cardiac damage via systemic inflammation. And we're suggesting that there are actually markers, or prognostic markers, that the clinicians should use to warn which one of the patients should avoid from using the glucocorticoid. So CD177 and LY6E, which are all LY6 family proteins, are what we're suggesting to be used as a marker, and could be proved to have the diagnostic value. For how we got to the finding is that we first looked at the CRF, or the case report form, from the infected patients. We first looked at the high dimer, which is a marker for thrombosis or cardiac disease. We could see that these patients had an abnormally high value of the dimer, and they also bear the cardiac abnormality as well as chest abnormality. We also looked at inflammatory markers such as neutrophil count and a systemic inflammatory marker which is called C-reactive protein. And what we could observe in common is that subjects C19, C011, C011 for short, and C017 present abnormal clinical values among all these parameters that I've cherry-picked. When we looked closely at the CRF of these two particular subjects, we could see that their symptoms were very bad. For example, over here you can see they were painful, having headache and fever as well, and this patient over here had a cardiac symptoms, chest pain and nausea. And what we could also see in common was that they were both served or prescribed with dexamethasone, and I've actually checked the CRF again, and only a handful of people were treated with dexamethasone. So I don't have the exact number right now, but it was below third of them. It was below third of them who were actually treated with dexamethasone. So this, I would say, is a significant finding. looked further into the genetic data from their RNA sequence data. More precisely, when we looked at the overlapping markers of differentially expressed genes, we could see that C011 and C017 over here had commonly regulate genes that were in the same direction. For example, dark blue over here, really downregulated marker over here, were also reported to be downregulated in the C017. And over here, the highly upregulated marker for C011 was also shown for C017 over here. And this marker is called CD177. And you may not really see this because of its small figure, sorry, but this is LY6E, and LY6E is also kind of upregulated, as a moderately upregulated among these patients. And one more, the MYOM2 were shown to be downregulated, blue in both of the patients. So the differentially regulated markers, were CD177, LY6E, these are LY6 family proteins, and antisense and RNA to lysozyme, which is important for neutrophil, which means if you have low number or downregulated antisense RNA, you have highly upregulated lysozymes or neutrophil markers. And this marker with unknown function, as well as MYOM2, which is known for its activity for cardiac contractility. We did some literature survey, and indeed we could find these kind of signatures among various diseases that includes not only COVID-19 but also cardiac diseases. What we want to discuss in this study is that high neutrophil and dimer counts are both biomarkers of death risk or mortality in severe COVID-19 cases, as has been shown for many retrospective studies. And concomitantly, the glucocorticoids are the go-to or frequently served drug to severe COVID-19 cases. However, there has been no really benefit. There has been no real proof of benefit among the severe COVID-19 patients, yet there could be adverse effects. And what we want to say is we want to make a bold claim that actually they aggravate the disease by worsening the neutrophil activations, as neutrophil are not really sensitive than other blood leukocytes against glucocorticoids, as found by this research. And as you can see, in this Korean journal or remark, it has been the dexamethasone treatment. It has been debatable because it's not really proven if it's beneficial. But it was just the study recovery trial, the NEJM paper, which caused this bloating actually of upsurge of usage of dexamethasone, which could be dangerous. As you can see over here, it should be cautious. And what we want to say is to we've got to be cautious, because a neutrophil activation could actually worsen the progression of the disease.